CEN Written Exams Start. Question 1. A patient with a psychiatric emergency is placed on a legal hold, e.g., 5150. The CEN should: Option A. Allow the patient to leave if they are calm. Option B. Inform the patient they are on a legal hold and document. Option C. Call the police to discharge the patient. Option D. Ignore the legal hold. The correct answer is option B. Inform the patient they are on a legal hold and document. Patients on a legal hold, involuntary psychiatric hold, are not allowed to leave until they are evaluated. The CEN should inform the patient of the hold and document the process. The patient must be kept safe and in a monitored environment. The hold is a legal order, and leaving would be against the law. The CEN should not discharge the patient. Question 2. A patient with subarachnoid hemorrhage presents with a sudden thunderclap headache, nuchal rigidity, and photophobia. Which diagnostic test is the initial gold standard? Option A. Non-contrast CT head. Option B. Lumbar puncture. Option C. MRI brain. Option D. CT angiography. The correct answer is option A. Non-contrast CT head. Non-contrast CT head is the initial test for suspected subarachnoid hemorrhage, SAH. It has a sensitivity of 90 to 95% within 24 hours of onset. If the CT is negative but clinical suspicion remains high, a lumbar puncture is needed to detect xanthochromia, indicating breakdown of red blood cells in the CSF. CTA may be done to identify the source of bleeding, but CT is the initial diagnostic test. Question 3. A patient with a DNR, do not resuscitate, order is in cardiac arrest. The CEN should: Option A. Start CPR immediately. Option B. Confirm the DNR status and not start CPR. Option C. Call the family for permission. Option D. Ask the patient's primary nurse. The correct answer is option B. Confirm the DNR status and not start CPR. If a patient has a valid DNR order, advance directive, the healthcare team should not initiate CPR. The CEN should confirm the DNR status before withholding CPR. If the DNR is not immediately available, the CEN should initiate CPR unless the patient's status is known and documented. The family's permission is not required if the DNR is valid. Question 4. A patient presents with a sudden onset of sharp, pleuritic chest pain and shortness of breath, but no trauma. Lung sounds are decreased on the left side. What diagnosis should the CEN suspect? Option A. Spontaneous pneumothorax. Option B. Pulmonary embolism. Option C. Pericarditis. Option D. Pleurisy. The correct answer is option A. Spontaneous pneumothorax. Spontaneous pneumothorax occurs without trauma, often in young, tall males or patients with underlying lung disease, COPD, asthma. It presents with sudden, sharp pleuritic chest pain and dyspnea, with decreased or absent breath sounds on the affected side. Management includes observation, supplemental oxygen, or chest tube placement depending on size and symptoms. Question 5. A patient with a suspected globe rupture should: Option A. Have the eye patched and the patient placed NPO. Option B. Have the eye examined with a slit lamp. Option C. Be given 4 antibiotics. Option D. Be discharged with a follow-up. The correct answer is option A. Have the eye patched and the patient placed NPO. Globe rupture is a surgical emergency. The eye should be patched with a shield, not pressure, to prevent further injury. The patient should be NPO for possible surgery. Ophthalmology consult is needed. Slit lamp examination should be done cautiously if a rupture is suspected. Antibiotics may be given prophylactically. Discharge is contraindicated. Question 6. A patient with a suspected overdose of opioids has a respiratory rate of 6 breaths/min. The CEN should: Option A, administer naloxone 0.4 mg 4. Option B, administer naloxone 2 mg 4. Option C, administer naloxone 0.4 mg IM. Option D, administer a naloxone drip. The correct answer is option A. Administer naloxone 0.4 mg 4. Naloxone is the opioid antagonist used to reverse respiratory depression in opioid overdose. The standard initial dose is 0.4 mg 4. If there is no response, the dose may be repeated. Naloxone can be given IM or intranasally if 4-access is not available. The CEN should start at 0.4 mg 4 to avoid precipitating severe withdrawal in opioid-dependent patients. Question 7. A patient with a migraine presents with a unilateral throbbing headache, nausea, photophobia, and phonophobia. What is the first-line treatment? Option A, triptan, sumatriptan. Option B, acetaminophen. Option C, morphine. Option D, metoclopramide. The correct answer is option A. Triptan, sumatriptan. Triptans, 5-HT1B/1D receptor agonists, are first-line agents for acute migraine, especially when the patient presents early. They are effective at aborting the headache. Acetaminophen and NSAIDs are for mild headaches. Metoclopramide is an antiemetic that may be given as an adjunct for nausea. Morphine is not recommended for migraine due to poor efficacy and risk of medication overuse headache. Question 8. A patient presents with a fracture of the tibia and fibula after a motor vehicle accident. The patient has a palpable pedal pulse and sensation. What is the initial action? Option A, reduce the fracture. Option B, apply a splint to immobilize. Option C, apply a tourniquet. Option D, perform a neurovascular assessment. The correct answer is option D. Perform a neurovascular assessment. The first step in any fracture assessment is a neurovascular assessment: pulses, sensation, movement, color, temperature. Even if the pulses are palpable, the CEN should document the baseline to monitor for changes. Splinting is important to prevent further injury, but neurovascular assessment comes first. Tourniquet is for bleeding control, not for fractures. Question 9. A patient with capacity refuses life-saving treatment and wants to leave against medical advice, AMA. The CEN should: Option A, allow the patient to leave after documentation and ensuring the patient understands the risks. Option B, restrain the patient and start treatment. Option C, call the family to persuade the patient. Option D, call security. The correct answer is option A. Allow the patient to leave after documentation and ensuring the patient understands the risks. Patients with decision-making capacity have the right to refuse treatment and leave AMA. The CEN should document that the patient was informed of the risks of leaving, and the benefits of treatment, and that they understand. The patient should sign an AMA form. Restraint and treatment without consent are only permissible if the patient is a danger to self or others, e.g., suicidal, psychotic. Question 10. Which of the following is an ethical principle in emergency nursing? Option A, beneficence, doing good. Option B, non-maleficence, doing no harm. Option C, autonomy, patient's right to decide. Option D, all of the above. The correct answer is option D, all of the above. The core ethical principles in emergency nursing include beneficence, doing good for the patient, non-maleficence, avoiding harm, autonomy, respecting the patient's choices, and justice, fair treatment. These principles guide nursing practice and decision-making. The CEN should respect these principles in all patient interactions. Question 11. A patient with cardiac arrest has a rhythm of ventricular fibrillation, VF, on the monitor. The patient has received 2 defibrillation attempts and 1 dose of epinephrine. What is the next medication to administer? Option A, amiodarone 300 mg 4 push. Option B lidocaine 100 mg 4 push. Option C magnesium sulfate 2 grams 4. Option D sodium bicarbonate 50 ml equivalent 4. The correct answer is option A. Amiodarone 300 mg 4 push. For shock refractory VF/pulseless VT, the ACLS algorithm recommends amiodarone 300 mg 4/IO push after the second shock. A second dose of 150 mg may be given for recurrent VF/VT. Lidocaine is a second-line alternative. Magnesium is for torsades de pointes. Sodium bicarbonate is not routinely recommended except in specific scenarios, hyperkalemia, tricyclic overdose. Question 12. A patient presents with a wound that is dirty, deep, and contaminated. The CEN should: Option A irrigate and debride the wound. Option B close the wound primarily. Option C leave the wound open. Option D apply a pressure dressing. The correct answer is option A. Irrigate and debride the wound. Dirty wounds require extensive irrigation with normal saline to remove debris and bacteria. Debridement of devitalized tissue is essential to prevent infection. Primary closure may be delayed primary closure, to allow for drainage and monitoring. Pressure dressings are not the primary treatment. Tetanus prophylaxis is indicated. Question 13. A patient presents with a severe headache, fever, nuchal rigidity, and altered mental status. Which diagnosis should the CEN suspect? Option A migraine. Option B meningitis. Option C subarachnoid hemorrhage. Option D temporal arteritis. The correct answer is option B. Meningitis. The classic triad for meningitis is headache, fever, and nuchal rigidity, neck stiffness, often accompanied by altered mental status, photophobia, and vomiting. Prompt antibiotics, within 60 minutes of suspicion, are critical. LP confirms the diagnosis. The patient should be placed on droplet precautions initially. Empirical antibiotics include vancomycin, ceftriaxone, and ampicillin. Question 14. A patient presents with an animal bite, likely a dog bite. The wound is deep and contaminated. The CEN should: Option A irrigate the wound and close it primarily. Option B irrigate, debride, and administer rabies prophylaxis. Option C administer antibiotics only. Option D apply a pressure dressing. The correct answer is option B. Irrigate, debride, and administer rabies prophylaxis. Animal bites, particularly from wild animals, require thorough irrigation, debridement, and rabies prophylaxis, post-exposure prophylaxis, PEP. Primary closure is generally not recommended to prevent infection. Antibiotics are indicated for high-risk wounds, e.g., deep, contaminated, or on the face. Tetanus prophylaxis is also indicated. Question 15. A patient with a seizure disorder is in status epilepticus. The CEN should administer: Option A lorazepam, Ativan, 4 mg 4. Option B phenytoin, dilantin, 20 mg/kg 4. Option C midazolam, Versed, 10 mg IM. Option D valproic acid 20 mg/kg 4. The correct answer is option A. Lorazepam, Ativan, 4 mg 4. Lorazepam is the first-line treatment for status epilepticus. It is a benzodiazepine that terminates seizures. If the seizure continues, phenytoin or fosphenytoin is given. Midazolam may be used if 4-access is not available, IM. Valproic acid is a third-line option. Airway management and ABCs are priorities. Question 16. A patient with a suspected stroke is being evaluated. The CEN should: Option A perform a focused assessment, FAST, face, arms, speech, time. Option B obtain a CT head. Option C check the blood glucose. Option D: all of the above. The correct answer is option D. All of the above. Stroke assessment includes a focused FAST, face, arms, speech, time, examination, CT head to rule out hemorrhage, and blood glucose check to rule out hypoglycemia, which can mimic stroke. This is part of the emergency stroke protocol. A CT head is essential before TPA administration. Question 17. A patient presents with severe eye pain, headache, nausea, vomiting, and a cloudy cornea. Which diagnosis is most likely? Option A, central retinal artery occlusion. Option B, acute angle closure glaucoma. Option C, retinal detachment. Option D, corneal abrasion. The correct answer is option B. Acute angle closure glaucoma. Acute angle closure glaucoma presents with severe eye pain, headache, nausea, vomiting, a red eye, a cloudy cornea, and a fixed, mid-dilated pupil. It is an emergency requiring immediate reduction of IOP with topical beta blockers, alpha agonists, carbonic anhydrase inhibitors, and hyperosmotic agents. Miotic agents, pilocarpine, are used after the acute attack is controlled. Question 18. Which medication is used to manage postpartum hemorrhage? Option A, oxytocin. Option B, misoprostol. Option C, tranexamic acid. Option D. All of the above. The correct answer is option D. All of the above. Postpartum hemorrhage, PPH, is managed with uterotonics. Oxytocin is the first-line agent, misoprostol and methylergonavine are second-line or adjunctive agents. Tranexamic acid is a recent addition to the management of PPH, reducing bleeding and mortality. Uterine massage, fluids, and blood products are also indicated. Question 19. A patient with sepsis has a MAP of 55 mmHg despite fluid resuscitation. The CEN should anticipate which vasopressor? Option A, dopamine. Option B, norepinephrine. Option C, phenylephrine. Option D, epinephrine. The correct answer is option B. Norepinephrine. Norepinephrine is the first-line vasopressor for septic shock. It increases MAP through vasoconstriction and is preferred over dopamine due to a better safety profile. The sepsis protocol recommends early broad-spectrum antibiotics, within 1 hour, 30 ml/kg crystalloid, and vasopressors for fluid refractory shock. MAP target is 65 mmHg. Question 20. A patient presents with preeclampsia, headache, visual changes, epigastric pain, and elevated liver enzymes and platelets. This patient is at risk for Option A, eclampsia. Option B, HELLP syndrome. Option C, placental abruption. Option D, preterm labor. The correct answer is option B. HELLP syndrome. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. It presents with epigastric pain, nausea, headache, and visual changes. HELLP requires immediate delivery to prevent maternal and fetal morbidity/mortality. Magnesium sulfate is used to prevent eclampsia, and delivery is indicated. Question 21. A patient with suspected C. difficile infection should be placed on which type of precautions? Option A, contact precautions. Option B, droplet precautions. Option C, airborne precautions. Option D, standard precautions. The correct answer is option A. Contact precautions. C. difficile is transmitted via the fecal-oral route, contact with contaminated surfaces or feces. Patients should be placed on contact precautions, gloves and gowns, with hand hygiene using soap and water. Alcohol-based hand rub is not effective against C. diff spores. Private room is preferred. Droplet and airborne precautions are for respiratory infections. Question 22. A patient's ECG shows a heart rate of 40 bpm with wide QRS complexes and no association between P waves and QRS complexes. This rhythm is Option A, sinus bradycardia. Option B, atrial fibrillation. Option C, third-degree AV block. Option D, ventricular escape rhythm. The correct answer is option C, third-degree AV block. Third-degree, complete, AV block is characterized by complete dissociation between atrial and ventricular activity. The atrial rate is usually faster, P waves, than the ventricular rate, wide QRS escape rhythm. This is unstable and may require transcutaneous pacing or atropine, though atropine is less effective for infranodal blocks. Question 23. A patient with hypothermia, core temperature 30 degrees Celsius, is unresponsive. The CEN should Option A, rewarm the patient with active external Ruhrmetting, e.g., warm blankets. Option B, rewarm with active internal Ruhrmetting, e.g., warm for fluids, warm humidified oxygen. Option C, administer 4 antibiotics. Option D, defibrillate for VF. The correct answer is option B. Rewarm with active internal Ruhrmetting, e.g., warm for fluids, warm humidified oxygen. Hypothermic patients with temperatures below 32 degrees Celsius are at risk for cardiac arrest. Active internal Ruhrmetting is the priority. External Ruhrmetting can cause afterdrop or Ruhrmetting shock, peripheral vasodilation causing hypotension. Defibrillation may be attempted for VF, but if the patient is severely hypothermic, the heart may not respond until Ruhrmetting is initiated. Management is supportive. Question 24. A patient's blood pressure is 200/120 mmHg with headache, confusion, and nausea. The CEN should recognize this as Option A, essential hypertension. Option B, hypertensive urgency. Option C, hypertensive emergency with end organ damage. Option D, pseudohypertension. The correct answer is option C, hypertensive emergency with end organ damage. Hypertensive emergency is defined as severely elevated blood pressure, 180/120 mmHg, with evidence of acute end organ damage, neurological symptoms, renal impairment, cardiac ischemia, or retinal changes. Hypertensive urgency has elevated BP without end organ damage. This patient's neurologic symptoms indicate end organ damage, requiring immediate 4 antihypertensive therapy, e.g., labetalol, nicardipine, with gradual BP reduction. Question 25. A patient presents with a sudden onset of a severe headache, nuchal rigidity, and photophobia. The CEN should suspect Option A, meningitis. Option B, subarachnoid hemorrhage. Option C, migraine. Option D, both A and B. The correct answer is option D, both A and B. Meningitis and subarachnoid hemorrhage share classic signs: severe headache, nuchal rigidity, and photophobia. The differentiation is made with imaging, CT for SAH, and lumbar puncture, LP for meningitis. Treatment for both is emergent. A non-contrast CT head is often the first test for SAH, LP is used for meningitis, and if CT is negative for SAH,